Yeah, thank you, Sujata, and thanks, Chair, and thanks to all the participants, distinguished guests, and delegates. So we have no, it's the wrong one here. No, Yuddha SAPKOTA. Yeah, that's the one. Okay. I think we have had enough information of the global summit, and then this topic is a little bit different than the global summit. The first one maybe, but it's very much related. These topics, this data, the evidences I provide here is very justifying the need of the kind of the advocacy and the leadership required at the national level, which is the kind of the one of the objective of the global summit. So it's a global target, and the indicators on eye health has been set in the one of the World Health Assembly resolution in the 2021. We as the Peter mentioned earlier, we have had a very successful in having the kind of the global resolution at the global level and taking the endorsement of the government at the global level. But all those global things need to be translated at the ground level, at the national level, which is not happening as we wanted to be. So that is where the actual changes need to happen at the ground level, and then that's what we want to have a global summit. And then I want to show where we stand at the moment, since the 2030 is approaching very close. Now will be 5 more years to go. So the most important indicators what we are taking now at the moment, there are several eye health indicators has to be addressed, of course, and need to be improved. But the most important indicator which was endorsed in the WHO World Health Assembly was on cataract surgery and the refractive error quantity along with the quality. That's we call it the effective coverage of cataract surgery and effective coverage of the refractive error, which is 30% increased from the baseline and in the cataract, and the 40% increase by 2030 in the refractive error, effective refractive error coverage from the baseline. So the country with the high baseline aim for the universal coverage, of course 70% or more goes to the universal coverage, and then only the national data may not be enough because there are several population subgroup there. So the kind of the equity has to be also addressed in this indicator. That's what the WHO has mentioned. So why this indicator has been taken is these two indicators are the most cost-effective intervention. Could have been done easily in the past, but it's still a persistent problem we have, and that need to be addressed. And then this is the most important, the bigger magnitude of the visual impairment and the blindness globally. And then also the huge unmet need in the cataract surgery is still there, and along with the refractive error. Therefore, the problem, the magnitude of the problem is increasing in the recent years and the years to come. So I will be more focused on the data and the information of the Asia region, because the Asia is globally almost more than 50% of the populations and accounted for more than 2/3 of the vision impairment problems. So when we said the indicator has been endorsed at the global level, but the country has to adapt it. But there is no adequate data to set the baseline for many countries. That was the kind of the issue. Therefore, the WHO has come up with the whatever available data to set the baseline as a reference baseline for the countries. So what it shows in the WHO reports in the global indicators is in a cataract surgery, that there are two threshold has been taken as a 612 and the 618 threshold. Among the 612 threshold, if you see the effective cataract surgical coverage, global median is quite low, is only the 17%. So the globally it has to reach by at least by the 30% point increase, means almost 50%, 47% it has to reach. And then similarly, if you take the threshold of the 618, it is a little bit better. The threshold means the need of the intervention for that purpose, the visual acuity less than 618 due to cataract, and then after intervention, the visual outcome become the 618. That is now that the current baseline is 24.8%. That's the where we stand. And then if you go to this global median to the WHO regions, so we see that South Asia seems to be a little bit better compared to the other WHO region, but we could see that the big difference on the range in the countries. So the bigger range. Some of the country is doing well in the Southeast Asia, that means, and some of the country is not good, is far low. So though relatively among all the other WHO regions, South Asia is better, but the bigger range, because we have many countries with the big disparities. That's what we see in the 618 ECSC. And another issue which I wanted to show you here is the difference in the cataract surgical coverage and the effective cataract surgical coverage. There is a big quality gap we could see in this report. Even though the cataract surgical coverage, the people who have got the cataract surgery, that's the cataract surgical coverage, and with a good outcome is effective cataract surgery. There is a big quality gap we could see in every WHO region. If we see here in the detail, what we could see that at the global level is the median global relative quality gap between CSA and the effective cataract surgical coverage is almost 34%. That means the 34% of the people who have had a cataract surgery have got the good visual outcome, 618 or better. That's the issue we have to address also at the moment. That's where we stand. So we can see there are big differences in each regions. The Africa region is one of the highest. The quality has to be addressed on that along with the quantity. And then the Southeast Asia is slightly better, but it's still 1/3 of the cataract surgery hasn't got the good visual outcome, 618 or better. That's what this WHO report says with available data. Similarly, in the effective refractive error coverage, which we need to increase in a 40% increment point increase in the baseline globally, which is 35% if you take the 612, the refractive error is usually taken as has to be a 6.6 or 6.9 good visual outcome, the very good visual outcome. Even we take the 612 as a threshold, the effective cataract surgical coverage at the moment is a 35.7% only. If it is taken as a 618 as a threshold, which is quite low, then we can see the coverage is 65.4%, because mostly the refractive error visual acuity comes to between the 612 and 618 need to be addressed, because it's already you cannot drive and it's economically difficult. So if you see with the available RAB data, with the 50+ data, if you see that the effective refractive error coverage, in the higher the age group, the less the coverage is there, and effective coverage also. So there is a quality gap issue also in the refractive error. The people in the refractive error, there are three kind of the met need, unmet need, and undermet need. So the met need is quite low, but there's a difference between the people wearing the glasses or wearing the appropriate correct lenses or not. That's also quite an issue. We see that in the Southeast Asia is not a big issue. Is people who wear the glasses is almost wearing, and 3% of the people not wearing appropriate glasses, but it varies in each region. So globally, if it has to be addressed, then this also need to be considered. So I'm showing some of the data which is available. That's the WHO data at the global level and the WHO regional level, and then the GBD level that they have analyzed and done the analysis. But when you see the country level in the Southeast Asia, many of the country doesn't have those baseline data individually. So they have to reference to the WHO average of that region. That's the kind of the issue we have to. The greener one is a kind of the available data at the moment, which WHO have used and the country can also be used. But you still see in the right side, the year is quite old data. Old data. You will only see that Nepal is the country who has the evidence of the visual impairment, EREC and ECSC data after the 2020. Otherwise, almost all the country in the world, in the Southeast Asia also still has to use the data older than the 2020 or even 10, 15 years older data. If you see in the country, just the three line, look at the three line highlighted here. Cataract surgical coverage, only if you take that as kind of the indicator, it looks quite satisfactory among the bilateral blind, among the people having the best visual acuity less than 360 is quite good in all these countries. But if you go to the WHO indicator, which endorsed in the World Health Assembly 612 or less, it's not much. First of all, the data is not available at the country level. And then only the Bhutan has available. That is also the 2017 older data, shows less than 40% coverage. And then the India has done the survey in the 2016-17, published in 2019. In the 612 level, it shows only 31%. And the Maldives slightly better, somehow, Maldives slightly better is above the 50%. If you see the Nepal, another available data is Nepal and Timor-Leste. Nepal data is quite recent. It's recently been disseminated, endorsed by the government, in fact, but the data survey was done in 2021, is a 35%. And then the Timor is another country where the data available is older data, of course, is a 30%. So what we see here is in the country level, there is a paucity of the data. A lot of things need to be done to evidence generation. First of all, they set the baseline, and they set that setting the target is already issue. And then another issue will also come, we'll discuss later. Once you set the target, achieving the target is another issue will also be there. So these are the things we stand at the moment, and then the IAPB has kind of the focus country. If you cannot do in the all country at once, so we have a kind of the focus country. We are very much active in these two countries for this evidence generation and achieving those global target, how to go on a global target. So thank you so much.
Thanks, YD.
Thank you, Mr. SAPKOTA.